We are now open for questions and would be happy to receive additional ones from the chat line if there are folks out there who do have questions. I would like to start off with a couple, however, that I have received, and I'll start off with one from myself, and it is really aimed at all of you. So you have all espoused various aspects of a team and the care of pregnant women through to babies being born and of course in between. And we are very privileged here at Cleveland Clinic and Cleveland Clinic Children's to be able to work with such a skilled team with fetal surgery, MFM, congenital heart surgeons and cardiologists with great expertise, but I suspect that there are many who do not have such resources at their facilities. And as a consequence, I'll ask what may seem like an obvious answer, but I'll ask it anyway, and that is if there is a concern for defect on the part of the fetus in an OB's office, for instance, what do you recommend as far as timing for referral to a cardiologist, a fetal surgeon, if one is available in the community, consultation with MFM? Is it as soon as detected and as early as possible? Repeat echoes? What is the general recommendation?
Sure. So I think in general, as soon as you suspect that there may be a defect or you know that there's a defect, I think that would be a good time to refer the patient. And I think in general, it's good to start with maternal fetal medicine, just to look, because often heart defects are not isolated. They may be associated with other problems and there may be genetic implications. So along with the cardiac issues with the fetus, the maternal fetal medicine specialist can kind of assess the fetus more globally, and then usually maternal fetal medicine works closely with pediatric cardiology, so they will then be able to get the patient also over in a timely manner for a more detailed assessment of the heart.
Yeah, and if I could add a couple of things, I think that referral in a sort of, relatively short order is useful for a lot of reasons. Obviously for the medical reasons in terms of assessing the needs of the fetus and the needs of the pregnancy overall, but also for sort of the psychological well-being of the pregnant patient and her family. Obviously there's a lot of worry and consternation when there's concern that anything is abnormal, and sometimes even through further assessment we can find out that these abnormalities are more mild or less significant than originally kind of thought, and that can put the family at ease. Even if they turn out to actually be significant, I think having the family understand what the next steps will be, what the outcomes potentially are, can still sort of aid them in accepting and becoming part of the process to help the baby.
I might just make a couple of comments. I think the timing of optimal referral depends, and it really depends on where you are and what your local resources are. For example, it may be that you have an expert maternal fetal program with broad capabilities of some types of fetal intervention, for example, but maybe you don't do open fetal surgery. So then the timing might be only for those cases that might require fetal interventions that you don't do. But the bottom line is we try to pride ourselves really in access, and so every referring physician has my cell phone number and is welcome to call me at any time, any day, 365, just to ask for an opinion or advice. And I think many of our providers have been really happy with that. And I agree with Fran. I think that there's a lot of value that we could potentially add, and fetal MRI and expertise in that has some variability in interpretation of those findings. Fetal echo has variability, and then the consultation for when we might need an intervention or how to affect the perinatal management. I think there's variability. And so we are just happy to provide input in whatever serves you the best. And then you can be the patient or it can be any referring provider, and we're happy to help in any way we can. Yeah, I would just like to say what we're really looking to do is just improving the access of high quality care and coordination of care. And from that standpoint, I think we look at it as what we can do to help you. And if that's just having a phone call and talking to you through these difficult cases, it really takes a village to raise a child.
So thank you. I would like to ask a question that just came through the chat line as follows. How do you handle international transport of a sick newborn with a complex congenital heart disease? Do you arrange everything related to that transport?
Yes. And really from the standpoint, it's critical we try to figure out the best time to bring those patients to us. And it's also, where we're looking to improve the fetal diagnosis is clearly the best transport modality is going to be the mother. But when it's a sick neonate, there's many ways that we can do that and have things at our disposal.
Thank you. To Dr. Ehrenberg, how can we improve and increase prenatal diagnosis of congenital heart disease?
So I think without knowing who asked the question, obviously the real answer is the sort of increase in skills, and it's mostly reliant on the obstetricians and maternal fetal medicine people who often are the first people that detect that either what is wrong or that something is wrong and send us the referrals. There also are a host of indications that we're happy to share with people that basically try to identify pregnancies where there's a known increase in risk. So the general sort of population risk of congenital heart disease is about 0.8% or 1 in 125 babies. We look for pregnancies where the expected risk may be 2 to 3% or higher as sort of an automatic indication for referral. This would include things like maternal diabetes, a 2-vessel umbilical cord, increased nuchal translucency, family history of congenital heart disease. But really, those pregnancies, some of them will have congenital heart disease, but the ones that the obstetricians and maternal fetal medicine people refer to us because they identified something as potentially being wrong are clearly the ones that have a much, much higher. So I think the answer really might be better provided by Dr. Chapa or, somebody else in terms of, to a certain extent, we rely on you guys to start identifying these.
Sure. So I think in addition to what Fran said, I think a lot of this begins at the locations where obstetrical ultrasound is being performed. Sometimes these are being done in OB offices, sometimes they're being done in radiology. And I think one thing that would help would be a standardized approach across all these varying locations to imaging of the fetal heart. And there are standards out there. But I think we need to improve education with the different providers who are doing these ultrasounds so that we can attain a standard that is then able to detect these things. For example, there are places where routine assessment of the cardiac outflow tracts are not performed with obstetrical ultrasound, and that misses a host of conditions if you just only look at the 4-chamber view. So it's standardization and education, I think, which will help.
Great, thank you. So just a little bit more administrative detail for those of you who may be around the world and interested in potentially sending a patient with congenital heart either in utero or extrauterine. So if you go to the Cleveland Clinic website, there is a link there for international referral information, and our global patient services can help make arrangements and partner with you to assure the best care is delivered to that patient and they get here in a timely and appropriate way. Dr. Chapa, when you have a pregnant mother who is carrying a fetus with congenital heart disease, how do you make a decision between vaginal delivery versus cesarean delivery?
That's a great question. So a lot of it, again, goes back to our team-based approach. So there is a lot of collaboration during the course of the pregnancy with pediatric cardiology and our pediatric cardiac surgeons, because we need to determine, we try to make a plan for that baby as soon as it's born. And so, as you know, labor and when babies are delivered is very hard to predict. There's so many factors, and we have no real understanding of when a baby's going to come a lot of times. So, for instances where immediate intervention is required in an infant or a neonate at birth, we often will make that decision to do a planned cesarean section at that time. Now, those cases are not the majority. They're a minority of cases, but it does come up from time to time. For most babies, we actually try to have them deliver vaginally, and it's better. And one of the things that's a little bit counterintuitive is that the circulation in the fetus is significantly different than the circulation in the neonate, and often the fetus is protected from the underlying cardiac defect as long as it's inside. So, and that occurs during labor. So the changes don't really occur till after delivery. So many of these fetuses will tolerate labor without a significant issue.
Dr. Cass. So there's reflection of the amazing procedures that you're able to do on behalf of these infants with various anomalies. Obviously, there is a great degree of expertise that is needed, and an entire team, as you alluded to in your talk. What do you think the need is for such centers around the world, but certainly maybe even in just the United States? Do you think it's necessary that all big centers have them, or should there really be centers of excellence that are fewer in number?
Well, that's an excellent question and very controversial, because the United States is a unique environment compared to other parts of the world. For example, Canada has a culture and a healthcare system that is based largely on regional referrals. And so they've begun to centralize fetal intervention type care to the large cities. And that system, culture, and financial setup permits that. In the United States, we have other challenges and other differences. I will say that it's a different time today than we were 15 years ago. 15 years ago, there were, originally there was one fetal surgery program, then there were two, then there were three, and actually I'm going to talk about this a little bit in my talk. But since the publish of the MOMS trial, publishing the effectiveness of fetal surgery in treating fetuses with spina bifida, there has been an increase in number, and that's not just been in the United States, but it's been globally. Prior to the MOMS trial publication, really there was very little fetal surgery outside the United States. There was fetoscopic interventions, laser treatment for twin-twin transfusion. That's been ubiquitous, but open fetal surgery was not being performed in very many places, and now it is. And there's a lot of reasons for that, so the question is complicated. I will say one thing, that we have to monitor quality and outcome. So that has to be the most important thing. So on one hand, it's a stress for a family to leave where they live and their local environment, their family, particularly in a stressful time. But on the other hand, they deserve to have the best care. So those two things have to be balanced. I will say that in the United States, actually in North America, there is the North American Fetal Treatment Network, which is a group of fetal centers that all work together, and we've developed databases, for example, for fetal surgery for myelomeningocele, where that data will be available and transparent, where we can look at outcomes and see are there big disparities in differences in outcome. It's possible maybe new programs can provide the same level of care, and it's possible that maybe there'll be more complications, and those are things that are going to be monitored and looked at. What we do with the information is going to be complicated, but It is an excellent question, and it's one to keep in mind for the future.
Dr. Cass, if this fetal surgery thing doesn't work out, you might consider going into the diplomatic corps. You did mention outcomes, which are very important, and we live in a very transparent age. The transparency of outcomes across our clinical programs is very important, and I think holds us accountable and is of use to families in making good choices. To Dr. Phillips, in this era of transparency and public reporting, do you think this leads to confusion for families, or do you think that in the specific case of congenital heart disease that is actually helpful in improving outcomes?
I think it's very important in improving outcomes. I think part of the problem is there needs to be clear definitions, and that's really where the STS has done a very good job, as well as the Congenital Heart Surgeon Society, is defining what are the metrics. I think we have very good metrics out there, and I think it's important that families are able to look at that across the board, and really looking at, from congenital heart disease, it's if the mortality, for example, at our center is 1.5% versus another center you're looking at that has a mortality rate that's 4.5%, 3 times higher, that has major impacts over the population. And being able for families to understand that quality difference, as well as really what the goals are, as you keep hearing, we're looking to team up with the families, the patients, local care providers. There are going to be times where you have to come to a tertiary and quaternary level center to get the care that might be many miles away. But what is that level of coordination of care to be able to get you back to your community? And I think that's the next step. It's what is the role of the family and the patient in understanding the data, and how are we going to help them to get better care?